Welcome to this special edition of the Diversity in Oncology Initiative, where we'll be hearing from community health leaders in Boston, Massachusetts, about how complex and unique obstacles to care affect their communities. Boston was selected as a pilot geography based on its diverse demographics. Gryt Health, in partnership with Bristol Myers Squibb, is bringing this initiative to life. I am your host and moderator, Andrea Suarez Vargas. I am a cancer survivorship coach, a patient advocate, and the founder of ASB Patient-Centric Solutions. I really appreciate we have the opportunity today to dive into this interactive conversation. As a Latina living in Florida for the past 12 years, I have personally experienced some of these challenges. I was born in Bogota, Colombia, and raised in a very different healthcare culture from here. It was my first time using an increasingly complex healthcare system 7 years ago when I got my colon cancer diagnosis. There were limited resources for the complexity of my diagnosis. And I felt isolated sometimes because most of the support and educational tools and resources were and are in English. As you may have noticed, Spanish is my first language. You know what? I struggled even though I was somebody who worked in the pharmaceutical industry for the Latin American market for more than 20 years. And you know what? I still struggle in navigating the healthcare system. This topic is important to me since access to good quality of care makes such a difference for my Latino community, just as it does for the Asian American and Black African American communities. Prior to today's session, we had the opportunity to meet with our panel. And we all agree that yes, we can talk about how to bridge the multiple barriers our communities face, but if we don't talk about racism first, we can talk about improving access to care and patient engagement. It is crucial for organizations to understand and acknowledge what experiences led our communities to lose trust, how organizations can begin to rebuild the trust, and ways to prevent those events from happening again. Organizationally, health equity is something that takes time and a collective effort to be addressed. So our panelists will be sharing some resources, tools, and strategies developed to better access and navigate the healthcare system as it is right now. So before we get underway, we have a special message from Jasmine Greenemeyer. She is the Executive Director of Global Patient Advocacy at Bristol Myers Squibb, and we are honored to share her words with you.
On behalf of Gryt Health and Bristol Myers Squibb, I want to thank you for joining this session. I'm affectionately calling it our Dialogue for Understanding. My name is Jasmine Greenemeyer, and I've been with Bristol Myers Squibb for under a year, but I was very attracted to coming to BMS because I felt like there was a lot of evidence of the company's commitment to patients and their family caregivers. And I've been on the other side of industry. I began my career as a health educator in an academic setting. I did medical ethics startup work for a little while, and I had a long run where I was a leader within a colorectal cancer patient advocacy organization. I bring this all up to say I've seen industry do it well, and I've also seen industry have some challenges, right? And how they've worked with the community. So I think that's why I'm just so proud that this session is happening, that our company really does lean in to understanding you have to start local and how important it is to partner with local leaders. But moreover, that you need to start with listening. And I've had my own unforced fouls where I've started with good intention and started with data, and we all know that that has its own shortcomings. So hats off to Boston. It's no surprise that we're beginning this conversation with Bostonians, and I say that because I really view Boston as quite the incubator. I mean, you see that from the new I say new, I mean, I guess the ongoing startup element in Boston, but also such an interesting cross section of communities, right? From a historical sense to how it continues to evolve. So to that end, I would be remiss if I didn't acknowledge that you're helping BMS be better. But I hope you also walk away feeling that you've helped your own community. And I think we have very similar goals. I think we're aligned that we want to remove barriers for individuals and their families to access healthcare, and that we need to start with a local understanding, both historically, but to be very also present with current circumstances. So to that end, I just want to thank Gryt Health for helping host this session, and to the BMS leaders that were involved in shaping this. But thank you for the time that you're making to have this dialogue. And again, at the end of the day, I hope it's useful for all involved. Thank you again.
Thank you, Jasmine, for your words. Your words are powerful. So our aim is to have an interactive conversation with you. So now we come to the first of today's poll question before we delve into the conversation. So on the screen, please answer the following question. To what extent do you agree or disagree with the following statement? I currently feel supported in trying to address barriers to care. The majority of the people, 38 of our audience agree with our statement, followed by somewhat agree. So were you expecting this result? So here comes the second question. If you had a magic wand in one or two words, state what type of support is needed to improve patient experiences and health outcomes for your community. Okay, so let's dive right in. I am humbled to have the opportunity to introduce you to our panel, to community health leaders from Boston, Massachusetts. So I want to introduce you to Chi Huang, the founder of the Asian Breast Cancer Project and the former executive director of Asian Women for Health. And also I want to introduce you to Leslie Gemfra, who is the community health educator in the Center of Cancer Equity and Engagement at Dana-Farber Harvard Cancer Center. Chi and Leslie, welcome, and please go ahead and introduce yourself.
Hello, everyone. My name is Chi Huang. I'm an immigrant from Taiwan. I came here in 1989 as an international student. And when I first came to this country, I can barely carry a conversation in English. So it's really a big deal and a real honor for me to be here today to address you and to serve as a panelist. Just wanted to give you a little more background about me. So I have a master's degree from Boston University. And when I graduated in 1991, I couldn't get any job because I don't have the cultural and linguistic capacity to get a job in the field, in the communication field. And I actually work at a calling center for a while, and that experience really exposed me to a lot of and improve my skills and made me build the resilience and to learn how to overcome objections and barriers. So as I mentioned, my personal cancer journey led me to the work that I'm doing right now. So when I was 40 years old, I was diagnosed with triple negative breast cancer. And that was a total shock to me because I don't have, I regard myself a pretty healthy person. And in fact, I just, I know enough to schedule my very first mammogram, right after I turned 40 years old. But the regular mammogram couldn't detect the tumor. And then a few months later, I felt the lump under my armpit. And that's how I knew that, and that's how my whole world was turned upside down. So as I mentioned, that my English was really not good. And although my family was very supportive and my husband was able to do to navigate the U.S. healthcare system for me, but I'm still having a hard time. And I also realized that many Asian women, because of the cultural and linguistic barrier, like me, they're not able to access the important information and support. So this experience led me to start the ABC project, the Asian Breast Cancer Project, to train other Asian women to deliver breast health education and peer support in Mandarin, Cantonese, and Vietnamese. So in June 2012, there were 6 Asian women we got together, and we thought that, how can we bridge the service gap, and how can we advance health equity for all of us? So the 6 founding sisters made a conscious decision that we wanted to expand the Asian Breast Cancer Project as a nonprofit organization, because we don't want to be limited to be a disease-specific program. And we want to actively promote health, and not just physical health, but also emotional well-being. As you know, there are many scientific evidence to link the mind-body connections. So I recently just retired from working at Asian Women for Health, but I'm still involved and open to assist on project and give talks to share my personal experience and also my professional experience, and how to engage and provide support in the Asian community in a culturally responsive and gender specific way. So I wanted to give the rest of the time to my esteemed fellow panelist, Leslie, to introduce herself.
Thank you, Shen-Chi, and thank you everyone for having me this evening. I hope everyone can hear me okay. So my name is Leslie Gemfra, and I am a health educator, a community health educator at Dana-Farber Harvard Cancer Center and the Center for Cancer Equity and Engagement. And so my experience in the space of cancer has not been from direct lived experience per se, meaning that I haven't had a personal cancer diagnosis, nor has anyone in my immediate family, but I considered it a scare. I was diagnosed with high risk HPV when I turned 30 years old. And I was actually really stunned by that, because I felt that throughout all of my young adulthood, and then like prior to the age of 30, I had done everything that I needed to do to be on top of all of my regular Pap tests and like just any kind of cervical cancer screenings. But when I turned 30, I was told that there is a particular sort of culture that is drawn or taken from the cervix, which is not typically done if nothing is noticed on a pap smear. So if there's no abnormal cells that have been identified, just like from like a visual examination by your provider, then prior to the age of 30, there is no further testing required. And so when I was 30, the testing was required. That was the new recommendation at that time. And so needless to say, I was like very, very terrified. And full disclosure, I have pretty significant anxiety. So I can kind of worst case scenario just about any situation if I let my mind get away from me. And so that situation was very hard for a number of reasons. Just as a Black woman trying to navigate the healthcare system, I feel as though at times providers aren't necessarily as like there's not as much time or direct like kind of communication with your care team as I feel like is needed in breaking news like that to somebody. So I was pretty stunned. And I think that the way it was delivered was also a bit like kind of matter of fact. And not to say that it wasn't professional from the perspective of the care team. It just like, I had no, like, I didn't even think that that was something that I had to worry about because I was always so on top of my regular screenings. And so I just, at that point, I became, even more hypervigilant and dedicated to like maintaining my overall health in terms of like, I had to get what is called a colposcopy to follow up yearly to make sure that no abnormal cells were forming. And it was also very stressful just because there was nothing going on with my body that I could obviously see or tell. And in fact, none of the cells on my cervix were considered unhealthy. So it's just, by the way, we have this positive test, and if we don't keep monitoring it, you could or possibly could not develop cervical cancer in the future. So I was just like very overwhelmed by that. And I just felt like I didn't have anybody that I could reach out to really process that information with in the care team, because it's not really about processing. It's about kind of delivering the information to the patient a lot of times, which I'm not saying is not necessary, but it's like from my perspective and from my experience, it wasn't enough. And so I guess I should also mention prior to that I had been working as a community health worker myself for a number of years since 2014. And so while I'm not the person who ever has had to deliver news about test results to a patient, I have been there when those results were delivered to patients to act as something of an advocate and or support system, just to be whatever the patient said they needed in that moment. So sometimes that would require just asking the patient, what do you need me to do? What would you like for me to do? How can I be of assistance? Would it be helpful if I attend an appointment with you? So there was just having that support oftentimes from the feedback I received from my patients and a number of my colleagues received from patients, like that was really critical. Just like the doctor has their job, but then there are other jobs within the healthcare system that are not often as recognized as is the case with community health workers that like are just as integral to like improving healthcare outcomes. And so that was what really drew me to come to the space of cancer and to really seek to want to work. In particular, the work that I was hired to do was around HPV and its related cancer. So it had that really strong personal significance for me. And I think that that's really what drew me to the space. And so I'm really honored to be here today. And I hope I wasn't too long-winded, but I'll pass it back to Andrea.
Thank you so much. And thank you both, Leslie and Shinji. Even though we belong to different communities, we face some common barriers in healthcare. So now that our team has compiled the results of our last question, I want to Emily share the results in the screen. I want to ask our panel to briefly share with us the words you chose and why you chose those words.
Mm-hmm. So I can kick us off first. So I think the word I will be choosing will be belonging. And I saw that in the chat box, people have identified, equality and diversity and inclusion. But I think that for me, belonging is the ultimate manifestation of what we want the patient to feel, that they receive a patient-centered care. So that's what I feel like. And I will put in the chat box that in the sense of healthcare, I think that, when we talk about diversity, equity, inclusion, belonging, what does it look like, for us in the healthcare setting? So this is something that I heard at different settings. So it says that diversity is a fact. It means that we should have everybody to have a seat at the table. And then equity is the choice, it's the goal that we wanted to make sure that everybody have it. It's not that we are giving everybody the same kind of resources, but we are giving people more resources if they need more help. And then inclusion is an action, is a practice. It means to have people, have a voice and they are able to participate. But then belonging, again, like I said, it means that we make people feel comfortable, feel welcomed. And it means that their voice are heard, and they're, so it's a patient-centered care, ultimate manifestation.
Thank you, Shinshi. What about you, Leslie?
So would it be helpful if I just chose something from the screen, or would I give my own answer as well? Either way is fine with me.
Sure.
Okay.
Go ahead.
Well, so I saw, well, I can tell you my answer was originally just equitable access, and just to kind of echo what Shinshi shared, was really from the perspective of understanding what the word equity really, in the spirit of what that word is meant to entail. And I really find that equity is something, it's like a buzzword in our culture and society these days, which, I mean, I always think it's good for more people to come into liberatory like language and like understanding certain terms. But I feel that equity is really to center the communities and groups and the people who have historically and presently continue to be excluded and marginalized. And that doesn't mean like just including them, which I guess would be more equality, which means now you can use the same facilities that we can use. But it's also understanding the needs of a particular group or even an individual, and really tailoring and centering them in the care. And that means from the moment that they walk into the healthcare system, even if that point of contact is just over the phone, like a telephonic outreach, really centering the person and people that you're looking to serve in order to correct and restore faith that has been broken through a lot of historical injustices, and, like, to speak more plainly, like often just outright medical racism. And so I guess just in collaboration with my two words, I saw abolishing capitalism. And I don't know if that really speaks to me, because I think that the spirit of that is really talking about healthcare often is inaccessible to people because there's a lot of dollars, and like all of the outcomes and measures that are often assigned to the work that even as CHWs we're often charged to deliver is about driving down costs. And I find that when the bottom line becomes more or is often by design more important than the outcomes of the people that you're looking to serve, like then you've done a disservice even before the person has fully gotten to be seen and made to feel heard and centered. And I feel that when you center people, it really requires the bottom line to often be set aside. Like we all know that costs can be high, but I've worked with patients for a number of years who received Medicaid, and their experiences were significantly different from people who paid for their own insurance. And that really shouldn't be the case. And so I think that abolishing capitalism also really speaks to me in this case. So
thank you, Leslie. So for me, the word is action, because action in someone else drives change. And I think that it's time to move from rhetoric to action, really to start acting. And it's enough of conversations. We have like a lot of evidence, a lot of information, but it's time to, okay, let's move to action. Okay, and talking about action, let's move to the first part of our conversation, that is addressing the root causes. And so Chi and Leslie, each community and sub-community face their own unique challenges. Can you speak to some of the historical inequities experienced by communities you work within the Boston area, please? So I don't know who wants to go first.
I guess I can go first for a change. I think that well, that's a good question. And I guess I will speak partly from my own lived experience, and then also from the experiences of people in my own community. So in the city of Boston, I guess it is pretty diverse, if, you know, like meaning there are people from all different walks of life, whether that's different ethnic backgrounds, religious backgrounds, racial backgrounds, socioeconomic backgrounds, et cetera. You have like a good bit of people from everywhere. And while that on its like, you know, on its face, that's considered a good thing. But when you really probe deeper into some of the communities experiencing these historical challenges in particular, one of the things that I focus on as a health educator and when I was working as a community health worker was really understanding what they call social determinants to health. And that is like, I guess, another one of those phrases that is really popularized lately in the healthcare system, but essentially really figuring out why people's healthcare suffers for reasons that are not necessarily tied to their directly tied to their current health status, but are, I guess they would say, maybe more indirectly tied. But I find that they are extremely interwoven, meaning that if you are experiencing ongoing housing challenges, if you're experiencing racism in the form of like redlining, gentrification, all sorts of things, and then even if, to be more specific, around the Black and African American communities in Boston, if there has been a history of like busing and all of these things that people might see as being separate from how somebody's healthcare, like let's say somebody has diabetes, hypertension, or blood pressure, those things have a direct correlation. And so I really find that in order for anybody, and this is not to speak just on behalf of any like race or ethnic background or anything like that, but for anyone to be able to focus primarily on their healthcare, their other needs have to be met. Like you need to be able to know where your next meal or your next your, I don't know, just having a roof over your head, like that basic need of shelter and safety and overall like your daily your activities of daily living are addressed before they can even talk about like for example cancer. And I've worked with people who have had an ongoing cancer diagnosis, like they were currently dealing with a battle, whether that cancer had metastasized or it was more like just localized to one part of their body, who told me that they were willing to put their treatment to the side, and they needed to, rather, not even willing, but they decided that it was best to put their treatment to the side because, well, they needed to, they finally had received a voucher, for example, for Section 8 or housing, and there was no way that they were going to not be able to hit the ground running to search apartment hunt. And that's another thing, just because you have a voucher doesn't necessarily mean you have a place to live yet. And so there was no way they could make their next oncology appointment. And so things like that can really have a direct correlation. And I think that in particular, Boston the mayor, and I want to say it was Mayor Walsh, prior to his departure, racism was declared a public health crisis by the city of Boston during the era of like the George Floyd, Breonna Taylor, Ahmaud Arbery protests that were nationwide, but the city of Boston took the initiative through the Boston, the mayor of Boston, and that was released through the Boston Public Health Commission, that racism is in and of itself a public health crisis, because there were people at the time who, and Black people in particular here, who were protesting racial injustice at the height of a pandemic. And so a lot of what we saw was that people were not willing to sit inside their houses, even though social distancing was recommended and the kind of directive at the time, but they were like, no, that racism is just as much a threat to our safety and our health outcomes and our overall quality of life as is this global pandemic. So sometimes when we think of intersectionality, and I hope that people have heard of that term, but we think of the different ways in which people are impacted by different forms of oppression. It's not just one-sided. Sometimes it's twofold or trifold, et cetera, based on that person's lived experiences. And so in the case of Black people, during that time, protesting racial injustice and police brutality was, a priority, even over their health. And we already saw that Black people were more impacted by COVID than than white groups, because oftentimes they are dealing with other issues, especially related to those social determinants of health, as well as other health considerations that we often face. And so I think that you can't really begin to even tackle health disparities if you don't look at all the other ways in which people's health outcomes differ, and differ for reasons that don't make much sense. Racism should not be a reason that somebody's health outcomes are different from another person's.
Thank you, Leslie.
So I'm so happy to be able to share the historical inequities that the Asian population have experienced. So I don't know if folks heard about the term model minority. So model minority is a term that was coined by a white sociologist in the 70s. And essentially it means that all Asian Americans are supposed to be healthy, wealthy, and well-educated. And if, because, look at the Asian communities, they can make it in America, they can achieve their American dream. So for all the other minority group, if you don't succeed, then it's your own fault. So this is a way that we were pit against the other minority group. And the damaging impact of this myth is that because our proximities to the white populations, some of the Asian Americans also internalize it and do not want to share, or be the do not want to bring shame to their family or be the burden to the family, and also don't want to let other people know that we need help. But and also usually Asian Americans, we usually are lumped together as a one monolithic group, and when you lump all group together, you kind of mask the disparities that exist in the subgroup. So to give you example, the Chinese who live in Chinatown, Boston Chinatown, their socioeconomic status may be very different from the Chinese who live in Newton or Lexington or Andover. And the same thing, the Chinese who live in Newton, their socioeconomic status may be very different from the Cambodians who live in Lo. And so when you lump everybody together, you you cannot see the differences, and you don't. And we all know that sometimes the policymaker or the funder, they focus on the data, and when you have limited or sometimes no data, we don't count. So I remember reading a statistics that only 0.19% of the funding goes to the Asian American community. So not even 1%, 0.019%. And at the same time, cancer is the number one, is the leading cause of death for both Asian men and women, with lung cancer that kills more, is the leading cause of death for Asian women and men. And I also learned that from the Boston Public Health cancer report, there's an 89% increase of breast cancer among Asian women from 1999 to 1913. And I'm one of those women. But, we still don't have, compared to other community, we still don't have the resources available to help increase the screening and to do the outreach education in the culturally and linguistically appropriate way. And we still have the lowest screening rate for mammogram, pap test, and also colonoscopy. So these are just some of the things that I want to mention. The model minority myth really is really hard on the Asian community.
I think you're on mute.
Thank you for that. So thank you, Leslie and Shinshi, for this. This is so educational, and no one understands the issues in a community like the people who face them every day. So, and I want to move now to the second question, and is, how does this type of generational trauma manifest today in how individuals access and utilize preventative care services such as cancer screenings? And I know that since you were touching a little bit of this in the previous question. So I don't know who wants to go first.
I guess I can follow up a little bit. So, so as I mentioned, I think that cultural and linguistic barriers are really the major factor to prevent, Asian women from access, or Asian Americans from accessing preventive services. I wanted to give you an example that, and also on March 30th, the Boston Globe actually have an article to talk about how there's a report to talk about how the Asian students feel, how they were treated at the Boston Public School. So the overall feeling is that we, as a community, we feel invisible. We feel that we're not represented, right? And the impact of that is that we feel, and also I know that there's many studies out there showing that Asian Americans have the least satisfactions towards their healthcare provider. They feel like they're not being treated, not being listened to, and they were put down. And all of this will lead to an example I can give you is that I know there was a woman, Asian woman, Chinese woman. She was diagnosed around the same time as I was, and she was 37 years. I'm sorry. She first of all, she felt the lump in her breast, and when she was breastfeeding her newborn, and she talked to her provider, but then the provider kind of brushed her off and said, well, it's normal for younger or breastfeeding mother to have lumpy breasts, and besides, Asian women don't usually get breast cancer. So but then she felt the lump that grew bigger and bigger. And then so after 9 months, so she finally get a biopsy. But then at the time, the cancer was already spread. And then the second time when she felt some back pain, and she went to see her provider, and the provider, instead of doing tests and things like that, she was treated as sciatica, and then another several months delayed, and she ended up had a very different outcome than I did. She died, and so terrible things happen, and I think that we really need to listen to the patients, and not just and listen to them, because I really feel like, patients know themselves better. Yeah, the best. Yeah.
So what about you, Leslie?
Yes, yeah, just kind of sitting with the story that Shin-Chi shared, and I was really I was touched by it a bit, of just to hear that she was kind of disregarded, and her pain was, or her experience with the lump was kind of set aside until such a time that, her outcome was not the same as yours, and it just made me, really reflective. So thank you for sharing that example. And just to kind of take up from where you left off, I think that in the Black community as well, a lot of those experiences are similar in that I'm not saying that providers that I've heard or any studies I've read necessarily have indicated that providers say that, oh, you're a Black person, so this type of cancer is not something that can be happening to you, but just that kind of not taking the experiences of the patient, the Black patient, as fact. Like, providers often, obviously, they've gone to medical school if they're a medical doctor, or if they're a nurse, then they've obviously gone through advanced training and education. But there's something to be said about people who work in the healthcare system, whether that's because they see a large number of patients daily, but they kind of seem to at times try to, I guess, paternalize to somebody else what they think the patient is feeling. And whether that means kind of brushing it off, or, well, I don't think it's this, but rather than listening to the patient, because I know I spoke earlier about my own issues with anxiety, but really trying to do everything within their power to make sure that the patient's doubts and fears have been addressed. I know that that's a big issue. And it's not only that, I also know that, as I kind of mentioned before, with the cost of healthcare, a lot of tests aren't necessarily indicated, meaning that providers aren't often ready to order certain tests if they feel that there's a less or more cost-effective solution to kind of addressing an issue. So whether that means you're going to come into an outpatient visit, I'm going to listen to you, jot down notes, make a record of it, but I think we can hold off and you go home, and then the patient maybe leaves feeling like, well, I'm not really sure. I feel like this is something more serious, and I didn't get the attention that I really felt that I needed in that moment. Oftentimes that's an experience that Black patients have. And not only that, also just, to be quite frank, a lot of community health centers in the city of Boston, the doctors do see a lot of patients, and the staffing or funding even for those health centers, in my opinion, is not always not to say not at all, but not always as culturally relevant, I think, as it could be. Meaning that when we talk about equitable access, we're not just talking about the fact that there is a clinic in your neighborhood. We're talking about, is that clinic and are those providers reflective or representative of the community that you come from? Can you relate to them? Are they people that look like you, that have similar lived experiences as you do? And that really does create a real natural trust, because what we see about groups of different people of all different racial or ethnic backgrounds is that we tend to gravitate to what's familiar to us. And there's nothing wrong with that. And if I'm being honest, from my own lived experiences, I had to start requesting providers that looked like me. That doesn't mean I always got on the best with them or we always developed that natural rapport. In fact, there's definitely been times where there have been providers who were Black that were not the best fit for me. But like, to have that option, I think a lot of white people don't necessarily know how important that is. And I don't just mean like, and even thinking of, you know, people who present as white but don't speak English, like I'm sure that they have some similar experiences to like what I'm describing, like to have somebody who speaks your language, who looks like you, who is really somewhat culturally familiar to you, is really just an experience that cannot be discounted. And I think oftentimes a lot of people in the Black community don't have that. And I think people take for granted when that's not a consideration that they have, like how valuable that is in just forging and fostering trust with the providers and the healthcare system that's in your community. So it's not just you have a clinic here, it's 5 minutes from my house, but who is there? And do I feel that they are going to hear me out? Do I feel that within this 30-minute, 20-minute visit that all of my concerns were heard? Or do I feel like they just got what they needed to build my insurance company? And oftentimes people do feel that they're being treated differently based on what insurance they carry. If they pay for their own insurance through their, or if they're on an employer sponsored health plan, they often report different outcomes just in terms of feeling heard and feeling as if the providers have centered them. And I really feel that centering the patient for the length of their visit is so critical to outcomes and for people to continue to follow up and not get lost to follow up, as we call it, like meaning that if you call a patient after you've made an initial point of contact and they're no longer picking up, that might be because they felt alienated. And oftentimes when you do screening, patients do report that the reason I stopped going is I felt alienated by the care team. I did not feel heard. I did not feel represented. And so it was easier for me to just, go on about my daily life and not deal with that. And that has really disastrous outcomes at times, especially when we're talking about oncology. So I'll pass it back to Andrea.
Thank you, Leslie. I feel you, and I've been there. And yes, we know that some organizations are prioritizing health equity, and they know that they need to make real changes, but also they need to take a humble step back and listen, and to understand the wide range of perspectives of our communities. So this leads us to the next topic, that is trust building. And healthcare organizations have a history of an current problem with mistrust. So this question is for Leslie. How do you balance trust building with expectations in your role with communities that have experienced medical racism, specifically in terms of clinical trials?
Yeah, thank you for the question. And I think that it's really relevant to the work I do, because one of the areas I do focus on is clinical trials. And I want to make sure that I answer this thoroughly, but try not to go over time, because I know I've kind of been doing that a bit. But I think that for me, the most important thing is to really go into the communities that I work with without an actual expectation. And that doesn't mean that I don't want to be effective, but it means that I don't want to go in there with my own preconceived notions, in particular when we're talking about the Black community, African-American community, people from the Black diaspora or African diaspora. I don't want to go in there with an agenda, meaning that if I'm really hoping to have an effective initial communication, meaning I'm just going to go in there and, maybe even the first meeting is introductory and there's no ask attached to it, meaning that I'm not going in there saying that, oh, and by the way, I think that you should consider clinical trials and they're great. I feel that when you go into a community, especially communities that have been historically marginalized, especially the Black community, if we're talking about the space of clinical trials, I'm just thinking of Tuskegee and the experiments that were done on the Tuskegee airmen who had a diagnosis of syphilis, and the U.S. Public Health Service was conducting or gave them lifetime access to healthcare, but did not necessarily, there was not informed consent, meaning that they were not given all of the particulars of the study. And in fact, care was withheld in order to study how the disease would naturally progress in Black men. And that was done deliberately. And so when you think about a harm like that with such lasting implications, I'm also thinking of the story of Henrietta Lacks, whose cells were harvested when she was diagnosed with cancer. I believe it was cervical cancer. And her cells have what are known as the HeLa cells. And now those cells have been studied by scientists and researchers for a generation, because there was significance in how her cells responded to her cancer, and how it has furthered it's created scientific advancements, but at the expense of not informing her that this was happening. And I think that when those types of injustices are seen, people are naturally going to be, well, why should I trust you? Like, I mean, fool me once, shame on you, but then, the rest of the same. And so I think that when I go into communities, what I'm really seeking to do is, as much as I have, I guess, a job to do in delivering health education, I seek to hear perspectives and also get a sense from the community what they want from me, similar to the principles that I shared that I use in my CHW work. I want to, what do you need from me, if anything at all? And maybe the answer is nothing. Maybe the answer is, we know that they brought you here to see us because you're Black and we're Black, and maybe, they might see that as some sort of tokenization. And if that's the case, I have to respect that. But I also try to, in being effective, gauge or read the room, as we say, get a sense of what the group that or the audience I'm working with wants from me. If I sense that there's an opening and there's a dialogue that is progressing naturally, yes, I might introduce the topic of clinical trials. I've had groups that are like, well, we don't think this is necessarily the right topic for us, but we're interested in information around mammography screenings or and so really trying to build inroads and not going in there with that agenda, as I mentioned, has been really, I think, the biggest piece of, that's been the biggest lesson that I've taken away from these groups that I've worked with, especially the Black community, because just because I'm Black doesn't mean that people are going to trust me. Yes, that can often facilitate trust, but I also don't want to use that as an in, oh, well, I'm going to tell them what I'm, charged to tell them and expect them to take it. I really want to be as resourceful as possible, while also centering the needs of the people that I'm working with.
Oh, thank you. Thank you, Leslie. I want to move on to the next question that is for Shinchi. And we know that COVID exacerbated existing inequities. And by the way, the President Biden administration will end the public health emergency for the coronavirus pandemic tomorrow. So how have feelings of shame and blame impacted the Asian American community in terms of both their physical and their mental well-being?
So I was just at a meeting where the Asian communities and Tufts University have a campus community partnership. And there was a recent study done at the Boston Chinatown Neighborhood Center to look at the COVID impact on the Chinese population, both physically and also mentally. So what we learned is that the community has a rude awakening right now, because like I said before, I think some of the people think, oh, bad things only happen to Black and brown people, but now we have a rude awakening that racism not only just happened to them, but also, happened to Asian Americans. And in fact, again, a lot of the impact on COVID in the Asian community, not reported, but I learned that because a lot of the medical professionals and nurses are of Asian descent, they so the Asian American actually have a high mortality if they're hospitalized after they got COVID, and this is again underreported. And so some of the impacts that we know of is that because of this racism, and because we're blamed to be the cause of the disease, many Asian American, particularly elderly, are afraid to go out to use the public, to use any public services, including going to get their medication or going for the doctor's appointment. So let alone the screening rate, right? And I forgot to mention that I think that in the Asian community, we did a research that, some of the Asian Americans don't have the prevention, concept. They think that we only need to go to the doctor when we're sick. We don't go to the doctor or do any tests. It's unnecessary, right? And also, I think that there's a fundamental difference between what we think is the, how we should treat. I think that a lot of people think that the Western culture is like really like killing and destroying, like the chemotherapy, like you just, it's not treating it, you're just treating the symptoms, you're not treating the root cause. So a lot of the Asian patients, they actually more opted to combine or use the more holistic approach in terms of cancer treatment. Sorry, I'm a little bit sidetracked. So yeah, so Mayor Walsh declared that racism is a public health issue, and I think is definitely true, because racism imposes an added health burden to the community, right? How we look, how we speak, often have an impact on how people treating us, and also how I think that after COVID, a lot of the Asian Americans just really even more determined that we're not our parents, Asian Americans. We are here and we belong here, and the choice that we make today will shape the choice that the treatment that we have tomorrow. So speaking of clinical trials, one thing I wanted to bring to people's attention is that most people here know about the Tuskegee incidents in the African-American community, but most people aren't aware that during the World War II, the Japanese actually did a lot of human experiments on the prisoners of the war or the citizen in their colonies. So for some of the older generations, they also are very suspicious of research or clinical trial and things like that. So what I found, because Asian Women for Health was involved and we were the East Coast regional lead for a national study called All of Us. So the goal of the study is to collect over 1 million people's specimen, and they do extensive lifestyle interview so that we can gather all this data so the scientists can practice precision medicine. So, you know, we can find cures, we can predict diseases. So what we found that's effective is that we tell the Asian prospects about the clinical trial, and we say that if you're not doing this for yourself, then do it for your family or for the future generation. So this is, you know, just I think that whenever you want to engage the Asian community, you have to consider the family dynamic, and also to think about like the unit in the Asian community is we emphasize more on community than individual. So that's oftentimes a good entry point when you tie that to the well-being or the welfare of the entire community or the family.
Yeah, so you, well, Asians in America face definitely like a multiple pandemic. You face like the biological pandemic, the fear of racist abuse, and on top of all these anxiety of living through COVID-19. And as a matter of fact, I want to share with you that therapy is predominantly white field in the USA. 80% of psychologists, 60% of counselors, and 59% of social workers are white, according to Data USA, a website that constructs visualizations of public federal data. So, all right, let's shift gears and turn to how to cultivate an inclusive healthcare system. So this question is for Xinxi. What are some of the cultural nuances within the Asian American community, and how can healthcare providers be mindful of these to increase engagement in healthcare services?
So I just mentioned that, you know, family dynamic, you know, the provider needs to be aware of that because usually it's not just the patient in the room, right? The whole family is coming. And I think that this is also similar to some of the other community. And then also the hierarchy, right? So men versus women, the elders versus the young people. And also I think that so because I'm involved with this again, Tufts has a CTSI group, and what we often do role play, and we tell the future researchers that, you know, when they're trying to do the informed consent, they really need to talk to the patient directly, and also have to tell the patient to repeat back to make sure that they really truly understand, because sometimes the Asian patient will, you know, will nod their head, you know, but it doesn't mean that they agree with you or they understand. They're just being polite, you know. So you want the patient to repeat back what you said to make sure that they truly understand. And I think that an example I can think of is that I remember that the Cambridge Health Alliance, they were doing some kind of patient survey, and they found out that the Muslim women, they don't feel comfortable wearing the hospital gown. So they created a what they call the modest gown for the Muslim women to put on. So the providers, and also they're not supposed to be, I think, be touched or be seen by male providers. So this, you know, there are certain things that I think that it will be helpful for the providers to know more about different cultures, but it doesn't mean that we have to be, we will be culturally competent in every single culture. You know, it's just that, you know, I think that if you treat the patient the way that you want to be treated, I think that you will have a baseline. Think of the patient as yourself or your family member. How would you like people to treat you, right? Yes. So.
Yes, and this is like a time to reflect from that for people that are joining from different organizations. If your organization understands the unique needs of the community and people that you are serving. And so, Leslie, can you speak to the significance of utilizing a peer-led approach, and how can providers support this?
Yeah, definitely. I think that the significance, first of all, is something that can't be understated, just in terms of if we're thinking about how any group of people communicates to each other. You think about like children to their parents, right? Often children are more comfortable with their siblings. Like, you can mess around and kind of like have a little bit more leisure or comfort dealing with a sibling, but when you're speaking to a parent, or I guess what I'm really trying to drive home is like that authority, quote unquote, figure, it can be a bit intimidating, and not necessarily because the person means to intimidate you, but just because there's that natural kind of parity or level playing field at play. And so I think that when you think of a peer-led approach, you think of what a peer is, it means that somebody who has similar, whether that is like a lived experience, if we're talking about any kind of like a diagnosis, or like even a mental health diagnosis, like somebody who's a peer means that they also have that experience with mental health diagnosis. So when you think of a peer-led approach, what we're really thinking about is making sure that the people who are training, and I'm thinking now of like community health workers, the people who are training community health workers, for example, have worked as community health workers and or patient navigators, instead of having and I'm not saying it can't be done, and often it is done, like a nurse care manager or a nurse or a social worker oversee community health workers. There's really not that parity, because we know that community health workers have the thing that distinguishes them from other members of the healthcare system, is that they often, and I guess some people might say should, and I kind of agree with that, live and or really have spent extensive time in the communities that they're serving. So they have an idea of the walk of life of the people that they're working with. So if you want to train people who have that walk of life, you want to make sure that you're training them from the perspective of someone who has that knowledge base, because there's specialized training and education that CHWs receive. It's not just like you have to get an advanced degree to become a CHW, but you have a particular dedication to the communities that you work with. And that's usually by design, because you are a member of those communities. So peer-led approaches, I think, are super important and impactful, because it makes the work that people do even more meaningful when you hear from somebody who has had to do that. Often doctors, social workers, nurses who work in like the health centers or the clinics aren't necessarily on the ground. And so I think that that's really important. So that's my answer.
Okay, so for you, Shinchi and Leslie, what is an example of a successful and culturally appropriate outreach program you have encountered? Do you want to start, Shinchi? Do you feel like you want to start?
Sure. Yeah, like I said, I will use the PI principle to meet people where they are physically, intellectually, and emotionally. So in the past, we have a program, we do nail salon outreach education to nail salon workers, because we know that they spend, a long time, in a work environment that they're exposed to chemical toxic ingredients. and they often don't think of, going to see the doctor or doing any preventative screening is top on their list. So we actually train our outreach workers to visit the 180 nail salons in the greater Boston area. And we, our outreach workers speak the language, and we have language appropriate materials that we leave with them. And we try to talk to them when they're having a slow time, when they don't have a lot of clients. And there was a time we were hoping to do the similar approach to the restaurant workers, because they're also the group of people who are exposed to a lot of toxic chemicals. And we know that the restaurant workers work long hours, but they usually have a break time during the afternoon. So and I think that in other communities, they have similar approach, like they have the barbershop outreach education for Black men and things like that. So that's just one example that I can think of. And also, I think that Leslie is absolutely right. I think that in order to bridge the service gap, we need to have more people, more service providers, more community health workers who look like the patient, think like the patient, and speak the patient's language. So Asian Women for Health also just got 2 multi-year grants to have this workforce development initiative, where we train and find jobs for underemployed and unemployed Asian Americans and other minority group to become community health workers. And so I will put the link in the chat box, and folks can take a look. Yeah.
Thank you.
Okay, so the same question for me, correct?
Yeah,
Okay,
that's
perfect.
correct.
So I think that, just like in the interest of time, I'll share one that I think is a really good resource. And I'll maybe just mention or put it in the chat for the other one that I'm not going to have enough time to share. The mammography, thank you. The mammography van, or the mammo van, as they call it, which is sent around. It's like a literal van that drives, I guess you could say, mainly in the city of Boston, but also other surrounding communities such as Natick, Quincy, Waltham, etc. And this is a partnership with the Office of Community Benefits at Dana-Farber Cancer Institute, as well as the community-based organizations that we partner, or they partner with, I should say, to actually provide mammography services inside of this van. So the van is like, it drives around to these communities and provides that service. And so there are like skilled nurses or registered mammography technicians that from Dana-Farber that actually go around performing the mammograms. And it is generally, I guess, directed, or it's targeted, I should say, for people from those marginalized groups, especially people who have financial, cultural, linguistic, other barriers that would prevent them from going in to have a traditional mammography in the healthcare center. And they're less likely to necessarily go out and get a mammogram, sorry, I don't know why I couldn't get that out, for that reason. So they offer these mammography services to them. And I think that the other one, it's more of a network, I would say, than a resource that anybody can access at Dana-Farber. We also, in the Dana-Farber Harvard Cancer Center, we also have what is called our Patient Navigator Network. And what we do is we come together at least quarterly to offer resources to, and it's like one of those peer-led groups, meaning that everybody who attends, aside from like our facilitator, who is our associate deputy director, is a patient navigator and or a community health worker, somebody who works to make patient navigation easier. And so then we share resources, and we also do case presentations, share best practices, etc. And that we really think that that's successful in improving outcomes for the people that we serve.
Okay, so just to let you know, our team and Emily is sharing some of these resources in the chat, and then after we end the presentation, we will sharing also these with you. And from our audience, we would like to learn from you. What are some outreach programs or resources that you know to be helpful and successful? So can you please type it in the chat, and so we can capture these responses and we'll make them available for our diversity in oncology community. We're getting close to the end of our time together. We have like 12 minutes left, and for Cincy and Leslie, like just to have like a very brief response on it's been said, how society treats its most vulnerable is always the measure of its humanity. So we know that action that drives change. And so what are the smallest steps each of us can take in the healthcare setting to work towards achieving equitable care for everyone? So if you can be as brief as possible, I will appreciate that.
Yeah, I think that, just to be super brief, that one of the easiest and most effective steps that people can work on taking is to really listen. And I don't mean listen to respond, I mean listen to take in what somebody is sharing. So even if that is, you're hearing like a hard no or no thanks or I'll pass, listen to that. And then take that in. And then maybe if at the end you're, determined to continue to try, maybe asking, for example, well, would it be okay if we if I reached out again in however long, say 30 days or so, and try it again, like really just listening and practicing that. And then not coming in with our own preconceived notions and then like trying to implement those ideas and or strategies, but listening to the communities that are experiencing whatever issue we're trying to combat. And then before we even attempt to offer solutions, listen to their experiences. And if that means, sitting with that, not trying to impose, then that's what it means. And really being as mindful and considerate to those needs as we possibly can be.
Thanks. Cincy, your turn.
Yeah, so I think to sum up, I think that the thing what we can do as an individual is that to have empathy, right? Like Leslie said, don't be judgmental and don't assume. Lesson, and I put in the chat box before, the principle of cross-cultural communication is to learn. First you listen, then you explain what the problem is or what you think the issue is, or ask, and then you, so A is acknowledge. You acknowledge the patient's feeling or their perspective, then you recommend, and then you negotiate. So that's the principle. And I would say that access is not enough. Acceptability is the key. Remember, the ultimate goal is that we want to have everybody feel that they belong here. Yes. Yes. Thank you.
Thank you, Cincy. So for me, it's like to be present, to show that you are fully present, the care of the healthcare provider, and honor also the power of silence, allow you like time to process the information that you are sharing. Unfortunately, due to time restraints, we're gonna have to skip the Q&A session. And this has been like so insightful, educational, inspiring session. So I want to pass it over to Hong Tang, the extraordinary person that is the core, the heart of this initiative. She is the Global Health Equity Co-Lead at Bristol Myers Squibb.
Good evening. Thank you for tuning in to this virtual session. My name is Hong Tang, and I am the Global Co-Lead for Health Equity for Bristol Myers Squibb PAN. a people business resources group. I first want to thank Leslie, Chinchi, and Andrea for a thoughtful and insightful conversation into the unique obstacle to accessing care in their communities in Boston. It is wonderful to hear from your lived experiences to give us some perspective about the barriers and successes that you have in your communities. I am always particularly moved by stories that have been shared through our community to help us understand, reflect, and to commit to doing better. This virtual session could not have come at a better time. May is Asian American, Native Hawaiian, Pacific Islander Heritage Month, as well as Mental Health Month. We want to inspire people to connect, have courage to speak up, and have compassion for others for their lived experiences. Working for BMS, our whole mission is centered around patient and health. We often remind ourselves why we do what we do by asking the question, who are you working for? For me, I am working for all patients who want and need equal access to health care. Patients are at the center of everything we do. They inspire us. They are the reason we come to work each and every day. Additionally, BMS has a deep legacy in addressing healthcare disparities, with progress against and perspective from bold commitments and initiatives that are actively increasing health equity. In conjunction with Gryt Health, the Diversity in Oncology Boston pilot is one example of the grassroots effort we are exploring. Other grassroots efforts address food security, cultural awareness and competency, mobilizing community healthcare workers and patient navigators to increase access among medically underserved patients and communities in oncology, hematology, cardiology, as well as immunology. We are recently reminded by Dr. Monica Bertonelli, the director of NCI, that achieving a 50% reduction in cancer mortality in the next 25 years will be impossible without health equity. We come from many different places. We follow many different paths, but we are all here for one reason. We recognize we can't do this alone. Tackling systemic issues like health equity requires collaboration across industries and across public and private sector. We are stronger together. Please join me to accept the challenge. With one another, we can change the trajectory of every life that needs access to quality health care. Thank you.
As Hong said, we have a lot of information to process. There were like a lot of facts and a lot also to reflect. We have to do definitely our homework. And so Shinchi and Leslie, on behalf of the Gryt Health and BMS team, we sincerely appreciate your invaluable contribution as authentic human beings and panelists you are or you were today and in your daily life. And thanks to your contribution to our webinar. I learned so much. I have a lot to process, but thank you for making my job easier. You are like a great panel. And a big thank you to our audience for listening and for definitely for your active participation since we start. And we value your input and helping us guide us what are the next steps in the work that we are doing. But most importantly, we want to learn what are we missing, what needs to be discussed that we haven't bring to the table right still. With that being said, have a great evening. And as Hong said, we are stronger together. Thank you so much. Namaste.